Welcome, everyone. This is Ronkat Usman with JBS International, and thank you for joining us for today's Stigma Webinar Series Part 2. We're grounding our response in Maryland and West Virginia, statewide efforts to reduce stigma through collective impact. Before we begin, I'd like to review some housekeeping items. Due to the high number of participants on this call, all participant lines will be muted for the duration of this webinar session. Please use the chat feature to get help on how to use Zoom or to chat with other participants. If you have any questions or comments, please submit them at any time using the Q&A feature. To open your Q&A window, please click on the Q&A icon located in the bottom center of your Zoom window. If you experience any technical issues during this webinar, please message us using the chat feature, which is located at the bottom center of your screen, or email us at arcor-ta@jbsinternational.com. Lastly, this is a recorded event and your participation grants consent to be recorded. The recorded webinar and PowerPoint slides will be available and sent to participants at a later date. Today's presenters are Marie Stratton, Melissa Clark, Rob Zellner, and Amy Snodgrass. Our facilitator today is Andrew Bell. Andrew, I'll turn it over to you.
Thank you, Ronke. And really grateful for the work that Donald did in the previous webinar in this series. I'm going to offer a very quick introduction. We're going to do a couple of polls and move to our presenters as quickly as possible. As Ronke said, we've got Marie Stratton from the Maryland Department of Health, who will be presenting on regrounding our response and intro and overview. Rob Zellner from Awakenings Recovery, taking a trainer perspective from this project. Melissa Clark from AHEC West, an ARCOR grantee perspective on how this project has impacted her community. And Amy Snodgrass, who's in the middle of spearheading its adaptation from Maryland to West Virginia. Very excited to have them, and we'll move to them as quickly as possible. We've got two polls with 5 questions each. Please don't overthink it. I'm very grateful that we have 170 people here. So if you want to go ahead and launch the polls, Ronke. Thank you. So we'll give 30 seconds to a minute, or once we've had over 100 people answer. Just wondering how often you hear some version of them, from never, rarely, sometimes, often, or all the time. So for whomever wasn't able to see the full question, if you want to just make your chat box, your poll box larger, you'll be able to see more. So the question at the top is, how often do you hear some version of the following? And starting to see some responses roll through. And you need to answer all for it to register through. So even if you don't have any strong feelings about one of them, just put any answer there so we can get the rest of your answers. That would be really great. All right, we're seeing often in all cases is the predominant experience that folks are having. And we're up over 50% of our respondents. And so we'll move on to the next poll. Similar question. So there's the results if folks want to scroll through them real quick. The leader in all cases was often, with the exception of people are using drugs, then they don't care about the health and there's nothing we can do to help. That was sometimes was more frequent than often. Thanks. Go ahead, Ronke. Great. So the question this time is, how much do these beliefs hold back your work in saving lives? We know the bottom line of the ARCOR grant is reducing mortality and morbidity related to substance use. So you've got those same 5 statements, and then the degree to which you think that it holds back your work in saving lives. got a balance, and as we have more answers come through, we've got more people answering significantly. It's great that we've got some folks who aren't seeing their work impacted at all by some of these statements or these beliefs. Because we still have the majority as significantly impacted. We'll give it about 10 more seconds here, and then we'll move down to our main event. Really appreciate y'all participating, and we'll share the results out. We're up over 50%. I'm going to end the poll and share the results. So feel free to take a look here, and I will be passing it over to Marie in just a moment. So yeah, in each of the 5 cases, we saw significantly as the leader. So it's significantly impacting the work that you guys are doing to save lives. So hopefully this will be of relevance and interest. Thanks for joining us. I know time is precious these days. And Zoom is hard to continue with. So without further ado, here is Marie Stratton.
Great, thank you so much for inviting me to be here today. Regarding our response is at the center of much of our capacity building and training efforts at the Center for Harm Reduction Services in the Maryland Department of Health. We use this curriculum as a central aspect of our training for counties that are implementing law enforcement assisted diversion programs, which Rob will speak to later. And we also offer it across the state to build and maintain support for evidence-based approaches to the overdose crisis. Next slide, please. So planning for this initiative began in 2018 as overdose deaths were continuing to sharply increase in our state. The slide on the left shows evidence of the 3 waves of the opioid overdose crisis in Maryland. 2020 data is still preliminary, but we lost over 2,000 Marylanders to unintentional intoxication-related deaths during the first 9 months of 2020, with the vast majority due to fentanyl. This is 12% more than during the same period last year. The graph on the right shows age-adjusted mortality rate by county. We still certainly have some areas, like many of you, saying, you know, we don't have a problem here. And as a result, may have an extreme deficit in available support services and evidence-based treatment. So this depiction of the data is really helpful in our community presentations. So Maryland was really one of the first states to declare a state of emergency in January 2017 in response to that sharp increase of opioid overdose deaths. This increased the amount of resources and infrastructure for support and also helped to empower the emergency management system to enable rapid coordination of all state and local resources in support of these public health initiatives. This is known as the Opioid Operational Command Center here in Maryland. So a year later, after this state of emergency was declared, state partners were looking at what are the barriers to implementing evidence-based responses so we can really make an impact and drastically reduce overdose deaths. We know what the evidence-based practices are and the strategies from decades of research. We are also so fortunate to have the Opioid Operational Command Center here, ensuring that our response is coordinated and strategic. So it's not a lack of knowledge or a lack of infrastructure or coordination that's acting as a barrier in Maryland. So through speaking with partners across the state, the reason why these evidence-based strategies were not yet implemented or were difficult to expand really came down to stigma and misunderstandings about substance use that are a part of our culture. So then our task was to determine, how do we go about reducing stigma? We found helpful resources like a 2016 publication from the National Academies of Sciences on ending discrimination against people with mental and substance use disorders and the evidence of stigma change, which we can include in our follow-up as well. So on the state level, their recommendations included community education to raise awareness and including people with lived experience at every step. We've seen that in our Grounding Our Response initiative, that presentations led by master presenters with lived experience continue to have significant impacts on their audiences.
Marie, I apologize. I just want to make sure that your slides are keeping pace with your presentation. Do you want to let Ronke Noda shift the slide when you're ready?
Yes, thank you. That's great, thanks. So we also have a fantastic model here in Maryland for community education with the ACE Interface Initiative. It was led by the Maryland Essentials for Childhood, State Council, Child Abuse and Neglect, and the Family Tree, where they continue to raise awareness about adverse childhood experiences and its impact on public health. So we really aim to replicate their community education model with regrounding our response. So here, we have the beginning of our scaffolding for change. To address stigma and support people in their learning and changing their response to the overdose crisis, we had to identify what are the biggest misunderstandings and myths that are preventing our communities from changing. So our goal was not to just do presentations on the impact of stigma for people with substance use disorders, but instead to directly address those common misunderstandings that continue to impede an effective response, and also provide that more in-depth education about public health and evidence-based approaches. So this would be our scaffolding or our support system for change in our response to the overdose crisis. So to start, we selected the curriculum topics. Here are the 5 topics we selected, again, aiming to get at the root of misunderstandings and address those most common and harmful myths. The first 2 are really looking at the social context in which harms associated with drug use occur. The last 3 looking at strategies, interventions, and frameworks to utilize for planning and implementing a response. So starting with the social determinants of health, why are communities impacted differently? Who has access to transportation, housing, or medications for opioid use disorder? So in that presentation, we discuss factors influencing change like racism, growing income inequality and unemployment, the impact of drug policy and interdiction on the drug supply, the iron law prohibition, it will continue to increase and continue to create increasingly potent substances, and the impact of incarceration on individual and community health, as well as upstream and downstream approaches to the overdose crisis. Next, we have adverse childhood experiences. So here we look at why do people use drugs? What's the connection between trauma and substance use? We know that people who have experienced 6 or more adverse childhood experiences, things like incarcerated parents, emotional or physical abuse, are 46 times more likely to inject drugs as an adult. That leads to the question, are all of our substance use disorder treatment providers also making sure to address and treat trauma among their patients? In this presentation, we learn about toxic stress impact on the brain development. We dive into that connection between substance use, opioids in particular, and trauma, and the importance of not just taking away people's coping mechanisms and providing safe, competent, and stable support. Next, we get to the stages of change, where we're really directly addressing those myths surrounding addiction, like needing to hit rock bottom or increasing punishment and consequences in order for someone to change. Instead, we educate our community on how does health behavior change. We discuss the importance of providing support and interventions that are appropriate for the stage of change someone is in, and look for proportionality in our services landscape to provide healthcare and social service support for the majority of people who use drugs that are in those pre-action stages of change. This model also gave us the framework of scaffolding. How can you support individuals and our communities through this change process? Next, we have MAT as overdose prevention. So this was really addressing the myth that MAT is substituting one drug for another, and answers the question of what is our most effective tool to prevent overdose death. Medications like methadone and buprenorphine can reduce the overdose death rate for people with opioid use disorder by at least 50%. So if there were medications this effective for other serious health conditions like cancer, it would be unheard of to not offer it to every patient. So in this presentation, we really aim to explain all 3 FDA-approved medications and how exactly they protect people, as well as discuss how stigma creates barriers to this effective treatment. And lastly, with the drug user health framework, we look at why is it so imperative that we build comprehensive systems of care for people who use drugs. We look at examples, case studies of who's implementing this framework really well, the importance of robust harm reduction programs as a protective factor for infectious disease outbreaks, and really how to apply this framework for your organization. So next, we identified subject matter experts to build out the curriculum. You can see them listed here on the slide. We're really lucky to have some internationally known experts here in Maryland. They include Bridging Environments for Health, Maryland Essentials for Childhood, Dr. DiClemente at the Center for Community Collaboration, who developed the trans-theoretical model decades ago, and Dr. Olson and Vicki Walters from IBR Reach, and finally, the National Alliance for State and Territorial AIDS Directors, or NASDAD, who developed the Drug User Health Framework. Next, we developed a curriculum review process. So we put together a review team that included a harm reduction perspective as well as people with lived experience. And we saw a lot of learning happening across our curriculum development partners and the review team, as everyone was coming to the process with different perspective and experiences. We then updated the curriculum 1 year later, having someone with a bird's eye view, Dr. Burnett, who was also looking at everything through a social determinants of health lens. We added new data and made sure there was more cohesive language. Next slide. So after the curriculum was developed, we hosted a series of intensive training events in the summer of 2019 to build out this network of 100 master presenters. Using that ACE Interface Initiative model, we recruited master presenters from every region of Maryland with all different backgrounds, professions, and roles in their community. By doing so, we've been able to reach a much wider array of audiences in every county in Maryland. We also utilize an application process. So we asked folks to commit to doing 4 community presentations, get supervisor approval to attend the 2-day event, and also included some knowledge, skill, and attitude questions to help determine, who's coming to the training and what's going to be present in the room. We developed a rubric to make sure that applicants, we were selecting folks with diverse perspectives, geography, wanting to reach every region, and knowing that each region is impacted differently. People with different roles in their community, lived experience, and also those with limited professional development opportunities. You can see photos here from our regional summits. We followed the 2-day training event with a regional summit focused on that topic, so master presenters could continue learning and also build connections in their community. And we provide ongoing support to that network of master presenters with monthly virtual learning collaboratives, as well as seeking out presentation opportunities for them to share their skills and experience. Next slide. So what we're looking at now is collective impact of all 100 master presenters across the state. We're working for that collective impact to help reduce stigma and discrimination experienced by people who use drugs, build support for those evidence-based approaches to the overdose crisis, and ultimately in the long term to help reduce that substance-related morbidity and mortality, that public health goal. So in the past year, we've completed over 150 presentations and reaching about 4,000 Marylanders. And 90% of folks who completed an evaluation reported that it increased their support for harm reduction. And with that, I will pause here and I think pass off to the next presenter.
Thanks. Go ahead, Rob. Thank you for your presentation, Marie.
Hello, everyone. Good afternoon. And I appreciate everyone taking their time out of their busy days to do this Zoom experience with us. So I'm Rob Zellner. I'm a Director of Client Services and the Methadone Coordinator at Awakenings Recovery Center. And I'm going to give you a little bit of my lens as a trainer, as a director, as peer support, as a person with lived experiences, being able to be inserted into different disciplines and capacities to watch harm reduction and the Regrounding Our Response initiative kind of get a lot of traction in our conservative community, and give a little bit from my perspective how things have shifted to a more less stigmatized way about we deliver services in Washington County, Maryland. Advance slide, please. So, law enforcement assisted diversion. I think it came to us as an expansion out of Baltimore City, I believe 2 years ago now. We in Washington County are the first outside of Baltimore City to have a LEADS program. What that is, it's identified champions. that have a help approach versus the punitive approach, where that was identified champions within our city and county law enforcement departments, were brought in for a harm reduction training and then part of the ROR series. That is where people like myself and a couple others with lived experiences and just working within the harm reduction lens were able to give our input and explain firsthand how this can be a benefit to law enforcement and not, it's another tool in their tool belt, right? It's another way to meet people where they're at. And honestly, through my interactions with law enforcement, I had some stigma, right? I had some bias with it. And from my own personal experiences, and to watch police officers just want to offer another option to help their community members was really astounding. And it really made me re-examine how I wanted to move forward as a professional in the behavioral health sector. Advance slide, please. So with Marie's team and the support of the Regrounding Our Response, this is where, again, we went into law enforcement and we were able to talk about, we were able to have like real candid conversations. We were able to break down some of the barriers for law enforcement. We were able to talk about their stigmas associated with drug use and intravenous drug use specifically, and what that has looked like in our region. And, we're able to talk some numbers. We have an SSP program, part of the harm reduction philosophy. And we were able to talk about numbers, and they were actually able to see the benefits of having an SSP and a harm reduction program in their community, and how we were able to assist people that may be directly related to some of the punitive measures done by law enforcement. Advance slide, please. So we've seen the 5 topics, and I'm a master presenter in 3 of the topics, as you can see on the slide. Before my director role, director of client services role at Awakenings, I was the peer support specialist supervisor for the Washington County Health Department's harm reduction program. This is where I got trained in these phenomenal topics and started to implement these in our community. And due to COVID, it kind of gave it a little hiccup, just with services no longer being rendered in person. Especially with us being one of the front runners, if not the first to implement the entire shutdown of services. And we've seen a dramatic increase in Maryland and specifically in Washington County due to COVID struggles. And we're starting to have more conversation with local organizations about trying to implement these topics. As we can see the increase of numbers due to the circumstances, nothing has really changed except for the increase in numbers. There's still the stigma associated. Some services are starting to be rendered again, but at a different capacity. Telehealth has kind of made this new way to go about interactions, but it's hard to reach people in rural Maryland sometimes due to bandwidth complexities, and maybe not even having any internet access, period. I mean, yes, there's on the phone, but if you don't have good bandwidth and if you're not in a Wi-Fi region, then it's really hard to be able to stay up with the times and be able to get the information that you're trying to get out of these trainings. Advance slide, please. So we have had we've had a little bit of a pushback, and I'm saying that mildly, with our county commissioners in relation to our relation to what harm reduction looks like in practice. Even though my 9 months at the health department We doubled our numbers from about 150 some to 300, and I believe it was 40 some by the time I left, mainly due to our relationship with our community and the population we were serving. Despite all of these efforts and these life-saving program and services that were rendered, there was still a behind-the-scenes bill that was just made without data and correct intel. And this was these are the struggles that we have here in a very conservative area in Maryland, with very progressive views by some, which I don't understand how health can be progressive, but we won't go too deep into that, and I apologize. But it's been a struggle at times, but we've had the community behind us, we've had local leaders, we've had elected officials all be on our side. So we keep working and building on what we have as a community built with the help of other regions. We built this community that is health, has a strong health perspective versus the punitive approach as we have had here for decades. And we are seeing the benefit, but it's really hard it's hard to keep the wheels turning whenever you have elected officials down in Annapolis kind of trying to throw a little bit of a wrench in the process. Advanced slide, please. So where introducing ROR to more of the community level was kind of halted due to COVID, what increased was the thought process between me, Marie, Dr. Stephanie Hutter-Thomas, about how to implement this in a way that we're reaching people exactly where they're at. And I had the bright idea in collaboration with Marie and Dr. Stephanie Hutter-Thomas to implement this into our facility. So Awakenings Recovery Center is started out more of an abstinence-based model, with the ROR series and supports from Marie and company. I was able to kind of at least get a space to talk about this, show this initiative and show the benefits of this. And, between social determinants of health, the whole way through, it made my higher ups value this. And what came up out of that was the addition to offering our services to people, to the populations that are completely underserved, at least at a treatment level from my perspective, when it comes to methadone. Buprenorphine and Vivitrol are more widely accepted, with the least amount of data on those two, less good data on those two, when methadone just has its own uniqueness to what it looks like as overdose prevention. I know just through data that an individual that comes to our facility, and after they leave our 30-day program, and if they were using opiates and have an opiate use disorder, they are substantially at a higher risk of overdose. If the individual is interested, we can get them set up once they leave. But prior to that, we will take people upon admission on methadone, and I work very vigilantly with one of our local providers at being able to go there, get their medication. It's administered under the supervision of our medical professionals at our facility. This in itself, to me at least, is a game changer for treatment facilities. This is absolutely meeting people where we're at. We're not going to tell people, hey, you can't take your insulin. You can't take your high blood pressure medicine. You can't take these other vital medications that you need to take just to maintain that homeostasis, so you're able to sit here and get your treatment. And methadone and other MAT options should not be any different as well.
Thank you so much, Rob. And it's fantastic that within your own organization, folks were able to shift from an abstinence-based, abstinence-only model to many pathways embraced with medication-assisted treatment helping save lives. Thank you for your presentation. Melissa, you're up. Thanks so much for bringing a grantee perspective to this.
Sure, happy to be here. Welcome everybody. I see 206 people. That's awesome. Great turnout. So I'm Melissa Clark. I'm actually the Associate Director at AHEC West. At AHEC West, we do all kinds of things within our community. We bring everyone to the table to have a conversation. That's what AHECs are most notoriously known for. But we also don't have all of the things that we have to go through because we are an independent nonprofit, that we don't have to go through some of the state mandates and things of that nature. So if I can have the next slide, I'll tell you a little bit about what we're doing. We started out in an R-Corps planning grant, and we formed, depending where you live, a consortium or a consortium. So it's spoken both ways depending where you live. So we have the Healing Allegheny Consortium, and part of it began as a planning grant within our community. We knew that we had a problem. We knew that it needed addressed, and we knew we needed to do something about it. So we were granted that initial planning grant, which then grew into the implementation grant. During the planning grant itself, we were able to really dig into the meat of what was happening and back it all up with data. We did focus groups, we did all kinds of things, probably similar to what some of you all who are here on the call did. If you look at the map that Marie showed, or the chart that Marie showed way back in the beginning, you see Allegheny County. We usually go back and forth with Cecil County on who has the worst overdose substance use issues. And according to that, we're third. So last year we were second. We had 111% increase in overdose deaths last year. In 1 year, 111% overdose. So it's pretty crazy, and we're really trying hard to make a difference. So the four main goals of our consortium are providing education on opioid and addicted related stigma to the general public, also to workforce, and also to include advocacy for harm reduction, because we know harm reduction works and we need harm reduction. Even in our little conservative county, we're going to have harm reduction. We expand access to prevention, treatment, recovery services. We promote the development of stable housing and other services for those in recovery, and provide targeted services for families who are affected by opioid and substance use disorders. Right now, at the table, every month, we have over 35 community members. And as a result of that, we have also now have, I think we're up to 5 work groups that are all involved with the consortium. And when I say they're asking us to have additional meetings because they are wanting things to happen, it's crazy, because usually we're begging, come on, let's just have a meeting on this. We need to talk about this. They're like, no, we need to do it. So they're making things happen. So next slide, please. And I will say, none of the people that are at the table are forced to be there. They all want to be there. So the way we started implementing the regrounding our response was we had AHEC West staff trained in all 5 areas of the regrounding our response, which both Marie and Rob have spoken about in their presentations. So we wanted to make sure someone on our staff we could call on at any given time for one of the 5 or all 5 a series. And so that was our first step in working with the regrounding our response. We next decided, well, our consortium needs to participate in this and get a better understanding. While most of them have one piece of it, they may not understand all 5 pieces or how all 5 pieces fit together. So we offered a series with the Maryland Rhoda, which Rob spoke of Dr. Stephanie Hutter Thomas. who's fantastic. And as we see here, it's a University of Maryland Rural Opioid Technical Assistance Program. Great, great organization. We have partnered with them, and Stephanie and I were able to pull it all together and have the consortium members. And we also invited any of their staff or partners that wanted to join in this series of 5. We did it for 5 weeks, I think on a Thursday afternoon or something. And it was just a given. So over 400 people were trained, and we averaged between 65 to 110 people per training, depending on the topic. This has resulted in the consortium members also joining other Maryland ROTA-led regrounding our response trainings. And it's also led to us as a consortium becoming certified to do the Maryland Addiction and Behavioral Health Professionals certification. So, oh my gosh, Andrew, I'm already almost out of time. Next slide, please. So how's it help? This is easy. It's help because it humanizes what is happening in our community. It reduces stigma. It opens doors for other partnerships. And now the consortium better understands what leads to the issues we're experiencing. All the things people don't talk about. This educated them on that. So next slide, please. In the future, we're going to continue to do the regrounding our response as needed whenever. We'll probably do another series this fall to bring more people in that haven't had it. We'll also be bringing additional partners that will need to be educated. We're expanding this education to our workforce, education, and faith community, which are three of the work groups under the consortium. And then we'll continue to partner with ROTA and, of course, Marie and everyone at MDH on the regrounding our response. Is that all I have? One more? I think that's it. Yeah. Amy, sorry, that went really fast.
Thank you so much, Melissa. Go ahead, Amy.
All righty. So my name's Amy Snodgrass. I'm from West Virginia, hence my beautiful background of our wonderful state. And I am honored to be on this panel with these awesome folks from Maryland. And I'm going to tie together and answer probably some of the questions that are in the chat of how you can do this in your state and adapt this wonderful curriculum. So I'm going to begin. Next slide for me. By answering 4 questions to guide the discussion. So I am Project Director of Implementation 1 grant. Our service area is in the darker green, and we are located about 2 hours south of Pittsburgh, just to give you some perspective. And then a little fact, a little cool note is the county in the center at the time of our implementation grant was not considered rural. It now is. So we're very thankful for that. So that answers the where. Let me answer the what. So to do that, I'm going to talk about one of our consortium partners, which is our health department, and answer the question of what work was being done that we found we really need some sort of a curriculum, a tool, right, to progress some of our initiatives that were happening. And our health department actually staffs peer support specialists in a few of the counties. And I'm going to use one of the counties as my example today for discussion. And so in Pleasants County, West Virginia, the health department has a peer support specialist that is the lead of the quick response team in that county. And we were meeting about a year ago, and we just finished our PIMS report. And so we were setting some goals, and that was to increase our referrals to our quick response team that was there. And so we were thinking, which leads to the next question of why. You know, he has a really good relationship with and getting a lot of referrals from a bail bondsman and a prosecuting attorney. So does a lot of work. There's a correctional facility in that county. So a lot of referrals happening there where the peer support specialist is diverting folks out of the correctional facility to treatment and then working with them when they leave treatment and connecting them to recovery services. So it makes this really nice model of continuum of care. So we wanted, though, to increase these referrals. So the next question was, Why? Why aren't we seeing referrals from the law enforcement or EMS? Despite the fact that we know beyond a shadow of a doubt that if you look in the paper in the counties involved, especially in this county, there's definitely arrests that are drug related. Couple of the critical members of our team in that county, one of them is a director of a Handle with Care program for the school system. So we know they're getting referrals, and we also know CPS referrals are on the rise because this was a year ago and we were all on lockdown at the time. So why aren't we getting referrals from law enforcement? So we started to look at the why a little bit. You know, are there some attitudes and beliefs that are present, and what can we do? Why are these happening? So that led to the how. And this, how can we get in and meet with law enforcement and EMS and make them aware of this wonderful team we have and the wonderful work they're doing? And that's when you're an R-Corps grantee, you have these awesome TAs from JBS that help with the how questions oftentimes. And so it was Andrew who was talking about this amazing curriculum from Maryland that was about to be launched virtually, which was perfect timing for us in West Virginia, because it was at that point we thought, well, you know what, let's look and see what that's all about. So reached out to Marie on the call today and asked, is it okay if we have some people from West Virginia that come into your training? And so I looked at our and selected key folks from our service area to attend, as well as some key folks in the state to get some feedback, because maybe this is something we can do here. And I'll tell you, all it took was the very first module, which was stages of change. And we viewed that and we thought, you know what, we need this curriculum. So the next question was how are we going to do that? And, adapt it to West Virginia. So that's where this process started, which leads to the next slide. And so what we did is we got a good understanding of what our local landscape, as far as what's already going on, because I think it's important not to reinvent the wheel sometimes. So we looked at our county coalition. We looked at the different quick response teams, kind of surveying, are you all seeing the same kind of things going on, which we did. We had a good pulse of what was going on in our service area. Definitely stigma present. Definitely still hearing things like, well, we don't have a drug problem in our counties. You may not see overdoses because as you move around in our service area, it's more, you see a lot of methamphetamine usage. So you're not going to see a lot of overdoses. But there's definitely arrests that are drug related. So looked at our prevention specialists. So West Virginia is unique in that we have prevention regions and we have prevention specialists that educate. But we had some really good things going on, but nothing like the Maryland Regrounding Our Response curriculum. So we knew we still needed it locally and within our service area. So the next slide. And then what I did is I reached out to our state, and the most important place to always begin when you're looking at your state and what's out there is the Office of Drug Control Policy. So the director at the time was Mr. Bob Hansen. I reached out to him and I'm like, is there something going on at the state that maybe a tool we can use for community education that we don't know about? And it was at the time that what was being launched, it was like perfect timing. What was being launched was a state stigma survey, and they were surveying all the different curriculum out there. So we have a spreadsheet that lists like all the trainings and who's doing it and what the subject matter is. And the reason for that too is to make sure that the wrong messaging isn't being communicated. So that was important, and that's going on at the time too. We looked at our state opioid response, what's going on there. We have terrific messaging. If you look at our state website for Office of Drug Policy, there's amazing links to trainings. So there were like stigma-free trainings going on. We had ACEs training going on because the wonderful Dr. Brummage is from West Virginia. So he's like the father of that in our state. So we had definitely those type subject matters, but we still needed something more. So what the next step was, first step, remembers, look at the stigma present, look at what's already going on in your state and your counties. And then we formed an advisory team, and our advisory team took a little time. We're right in the process of this, so it's great timing for me to share with you all today. So we formed a relationship with the ACES. We have an ACES coalition that's part of in West Virginia ACES coalition. We formed, that's part of our advisory team. West Virginia Primary Care Association is part of our group, and the Community Education Group. So we formed this awesome advisory team, and we are right in the midst of identifying the experts for the modules to do the adaptation, because wonderful Maryland Department of Health and Marie Stratton, we had conversations, are we good to, we've got to have this curriculum, because I can't, I see the need in our counties on a county and state level, and the permission was granted. And so we have identified our West Virginia experts, and then we've identified them, and we are right in the midst of doing the adaptation. We also have a student that will be working with us from West Virginia University that will be coming on as an intern, because we will be we're doing basically a pilot study, and then collecting the research behind the change of attitudes. So when we lead these trainings, are our referrals increasing? Because that's our goal. So then we also, ASTO which is Association of State and Territorial Health Officers, is working with the state of Maryland to develop a toolkit for adaptation. So we've reached out and working with them, because we're right in the middle of that process. So the next slide. This is my summary. So I'm a teacher, an educator. So I like visuals. So I love this slide. So what I compare this to is, this is springtime, and I don't know about you, but like I go outside and I look at my yard and I'm thinking, okay, and I assess it. What kind of weeds are coming up that I'm going to need to address because I want this flourishing yard. So I look at, addressing stigma and looking at what, what's going on in like that first county I was talking to you about, is we had to first address what are those weeds? What is that stigma that's coming up that we need to address? And sometimes you need to just pull that weed out, because I don't like dandelions. So I'm going to go out and pull that weed out. Similar to stigma, you got to address it. And it may just be like, maybe your county needs to start with just doing, or your service area you need to start with looking at training addressing just the language. So maybe you need to start with looking at that first. But for us, we've done that. We have an amazing media campaigns on the radio. We have billboards looking at stories of recovery. And so, but we still have these weeds that keep cropping up that are hindering the progression of our programs, such as in the case of the first county I was talking about. We need those referrals to increase. So we needed a larger tool to get at the stigma. And I look at Maryland Regrounding Our Response curriculum as that tool to get to the root, because we need to go in and work with those law enforcement and meet with them and have those difficult conversations. But the regrounding our response curriculums allow for conversations to happen, so we can open up that weed, pull it out, and where that stigma's gone, or at least diminished a little bit, so that programs can flourish and grow. So I hope that if there's any questions on how we can help move it to other states, I'm here to help, and Marie and her team too. So thank you all.
That was really wonderful, Amy. Go ahead.
At this time, we'll begin the question and answer segment of the presentation. If you've not already done so, please submit your questions by using the Q&A feature located at the bottom center of your screen. Andrew, I'll hand it over to you.
Thanks so much. I know there's been a chance to answer some of the questions in the chat box. One that we haven't been able to get to was specifically for you, Melissa. I see that you're typing the answer, but of the folks that you trained as staff, I know there are a number of folks in recovering with lived experience who are regrounding our response facilitators. But of the 5 that you guys sent, are any of the folks that were with AHEC West people with lived experience?
Yes, they were. We had one employee who has lived experience. So yeah, absolutely. They make the best presenters, and especially in the topics that she presented in.
That's really wonderful. Thank you. And so please add more questions to the Q&A. One question that did get answered, but I think there's an opportunity to speak a little bit more to, was a question about evaluation. So Marie shared that they're working with an evaluation team. In Amy's presentation, she shared that as they adapt, they're going to be working with West Virginia University. This is what would be called a innovative or promising practice, hence the Association of State and Territorial Health Officers adopting a toolkit for other states. But in terms of what folks are seeing on the ground in terms of change, hearing as responses from training audiences, do any of the presenters want to speak to what they've experienced as shifts in attitudes, either in communities to whom they're presenting or in themselves?
I can speak to that. I just wanted to, Jasmine had a question about the county coalitions. And I think that I think you provided that information, the Family Resource Network in West Virginia. But in our county, for example, there is no written legislation in particular on our consortium. In fact, like I said, it's everyone brought to the table. So, but we do communicate with others that are part of OOCC, the net, and the other networks as well. As far as the change in attitude, I think I always thought I knew more than I did. I thought I knew everything there was to know about social determinants of health and this and that, and really, I did the training for social determinants of health, and it was really eye-opening for me. Even though I've been working in this realm for a while, it really was eye-opening for me. And how to relate that back to Appalachia, where we live, was also, we had to tweak it a little bit for it to make sense for our setting where we are. And, you know, I would say a majority of the folks that go through it have learned something in all 5 of the series, because it is so, it's riveting, quite honestly.
Thank you so much, Melissa. And there'll be an opportunity with the last session in this series. Dr. Carla DiClemente and Stephanie Hutter-Thomas, who were referenced earlier, will be presenting on the stage as a change, an example of regrounding our response. Rob, maybe you can speak to this next question. How are you handling the behavioral health resistance to regrounding our response, or to other evidence-based practices that you see pushback to?
I think it's new. I think this is just very new for some people. This is not the traditional like addiction model. Harm reduction is still a very stigmatized and misunderstood philosophy, where people, at least that I've been in contact with, for some reason directly correlate a harm reduction philosophy with the syringe service program and safer injection equipment and that type of stuff. You know, it's more about meeting the providers where they're at as well. Although I will be very transparent, I struggle a bit with this. But again, me being a harm reduction expert, it's absolutely meeting them where they're at. So let's find some common ground. Are there things that don't even really need to be talked about currently because we're not even there in the context of this working relationship? If that's the case, then like, let's go to this other part. Let's talk about social determinants of health. Let's bring some people in that, you know, this directly affects. I must plug social determinants of health. That was a game changer for me when I watched it. Coming from my background, I thought I knew a lot of stuff about it. But behavioral health professionals, I feel, will understand the reasoning as to why we're going in this approach, because everything that we've been doing has failed. The direct impact of the war on drugs is a direct impact on the war on us, and it has failed. So it's time to readjust and, you know, refocus. And this is the way Maryland has been moving forward, with resistance at times. But I mean, we're being very resilient and still being able to be that new change for individuals in relation to receiving services with a like radical hospitality approach.
That's wonderful, Rob. And I've got a quick follow-up before I want to ask Marie a question about sort of response or change in law enforcement presentations. We do have an empty Q&A box, so here looking forward to see if there's others that come in. We got about 6 minutes left. Rob, you and Stephanie have talked about how the stages of change presentation really surprised you. You guys have provided a number of times because it created not just reduction in stigma, but different clinical space. So people looking at their behavior as nonlinear, looking at the fact that relapses or recycling is part of change. Can you speak to how that has impacted in surprising ways, not just staff, but clients?
I think the reduction of the word just relapse kind of changes the perspective of just substance use disorders. You know, from whenever you're able to do stages of change, it kind of strokes the clinical backbone, right? So like they get tangible evidence in their lingo as to how to understand the behaviors associated with just recovery in general. And it's not always just recovery seems to be the word, and it always translates to substance use disorders. But with that presentation, it's able to break it down into behavior specific situations, which in turn make it more tangible for people to grab a hold of that may be in the field with no lived experiences with substances at all. And when you're able to do that and you're able to meet them on their playing field, they're able to understand like the innuendos that come along with the rest of the presentation in relation to substance use disorders.
That's so great. Thank you, Rob. And I just want to highlight some of the interaction that's happened in the chat box here. And Marie, maybe you can speak to this in terms of the change experience being different to folks. If I'm listening to this and I'm listening and thinking about my community and think that I know they're really opposed to harm reduction. So how could any of this be useful to me? So talking about how this is scaffolding for change and change for where people are at in different places. Can you speak to that in the context of the beautiful point that you made in the chat box?
Yeah, I think that's something that I really learned and continue to learn through Grounding Our Response. And actually, a fellow master presenter pointed out to me that, you know, I may be expecting or really wanting people to understand and embrace harm reduction or a new approach really quickly, or, you know, wanting it to happen in a certain way, and just understanding that, you know, that's just not going to be the case. We're all coming to the table with different life experiences. So how can we be compassionate in how we're asking people to change? You know, a lot of times that requires some like difficult self-reflection. So how can we be compassionate about that and give people a lot of options? You know, sometimes it's like the cost savings of harm reduction that is going to convince someone. Sometimes it's the collaborative element or all of those kind of cross-cutting themes. So yeah, just giving people the options and the compassion through that change process.
That's really great. And so I want to do a lightning round to close us off with sort of 30 seconds each from our 4 presenters. And I want you guys to share something that's been a big takeaway or something you want to share as a result of one of the curriculums from Regrounding Our Response. And with 4 of you, we'll hit 4 of the 5, and maybe I'll try to round us out here. So 30 seconds on a big takeaway or an aha moment for yourselves in one of the 5 Regrounding Our Response. And you guys can choose, whoever goes first gets to choose first.
I'll go first. I think that I said I learned a lot of social determinants of health, but ACEs is the backbone of everything. So the adverse childhood experiences, love it. It feeds a lot of the other stuff and makes everyone understand it better.
That's great. Thank you. Melissa, who wants to go next?
I'll go next.
Oh, go ahead, Rob.
Go ahead, Amy. Go ahead.
I was going to talk stages of change and too as well. And the reason I say that is because we hear a lot regarding naloxone stigma stigma behind utilization of naloxone and EMS, how they have to keep going to oftentimes to the same locations more than once. And I think when I heard that, I just felt like, you know what, this could be a really helpful tool for us on that education piece for the EMS folks of why
That's wonderful.
often have to go back more than one time, so yes.
Yeah. Thank you, Amy. Rob?
So for me, I believe it was the MAT as overdose prevention, mainly because it was just a lot of data and a lot of good talking points implemented into one presentation that can A, start a conversation, and B, change a lot of myths. Like, it can just debunk a lot of myths that individuals have from just like mass hysteria from whether it's the news or just previous historical situations in relation to opiate treatment programs, so methadone clinics, as some people call them that. So to just see like tangible data as to like what should be best practices in relation to in relation to opiate use disorders, and actually having like a framework to show, not just talking, to actually show, peer-reviewed data just as to the benefits of it, can really change, at least I feel, the landscape of the stigma associated to MAT options in general, specifically methadone.
That's great. Thank you so much, Rob. And because we've heard Rob and Melissa talk about social determinants in their other question answers, Marie, do you want to talk about NASDAD's drug user health framework to close us off?
Sure, that's what I was going to pick too. I really like that topic really puts it all together. It puts all those other 4 concepts together. How do we provide comprehensive integrated care so we can, treat trauma, we can address the social determinants of health and inequities in our communities, consider the stages of change and what services we're offering for pre-action versus action. I really like how that really puts all the pieces together in a really helpful framework that people can then apply.
That's so wonderful. And one of the questions that got dealt with in the question box was whether or not any of the curriculum could be shared. Marie put her email in there. We're about to see it again in the final slide. And she said to reach out if folks were interested in that. And again, the next presentation in this series will be the Stages of Change delivered by the co-author of the Stages of Change, the world-renowned Dr. Carla DiClemente with Stephanie Hutter-Thomas. I'll pass it back to Ronke. Thank you, everyone who stayed. I know folks have some 3 o'clock, and we're up against it. So really appreciate all the engagement in the chat box and the Q&A and for taking your time to be with us today.
That concludes our Q&A portion. We would like to thank you again for your participation. Have a great rest of your day.